everyone. So moving into part 3 of this video series. This video we're going to dive into some of the muscular features that we try to leverage when sequencing our loading strategies, and we'll also get into some progressive loading strategies too that we might work through with the clients. And again, we'll do this once we've challenged the dissociation strategies a little bit more. So it's definitely not a case where we're just jumping from the dissociation drill that we talked through yesterday straight into a distal isometric strategy that we'll talk about in today's video. We need to consider that there's probably a couple of steps that we're going to work through before we reach shifting that load more distally. But just like the last video, we're going to speak about everything within the context of the same case insight, because we need to remember that this client had a history of 3 left ankle sprains, the same side as their current experience of left-sided low back pain. So even initially during the objective assessment, we want to try and identify the local capacity of the joint complexes throughout that entire coordinated structure. So we're looking at the local capacity of the foot and the ankle, and we'd even look at the local capacity of the knee as well. But we need to look at the local capacity within the context of the entire coordinated structure, right, to respect the global body region that we're looking at. So an example of one that we would use, you can see here the knee to wall assessment, just to get an insight into the dorsiflexion capacity around the ankle joint. We measure that with the toes about 10 centimeters from the wall. So this assessment here is essentially an ankle rocker assessment. So we move from heel rocker to ankle rocker to forefoot rocker as we progress through walking. And this gives us an insight into how well the tibia can translate forward, right, to bias more flexion and internal rotation at the tibia, right, to give us a further insight on the muscular level, the capacity of the posterior tissues of the lower leg to express more yielding isometric behavior, which for us, and the way we approach the assessment and the treatment process, for us that will give us an insight into the capacity for the distal portion of the lower limb coordinative structure to express a robust platform for the sharing of load proximally from distal to proximal. Okay, because this is important, because generally if we can't express that capacity, we may lose the capacity to manage stress distally, right? We may express more, perhaps more force production strategies distally, or more freezing strategies distally at the foot and the ankle that may limit that adaptability, right? Or we may see as another potential strategy, when we've lost that capacity distally, we may see increased muscle guarding around the foot and the ankle, or we may see a distribution of that workload more proximally up around the low back and the hip. So we essentially, and you'll see this a lot in the research, where when clients have a history of ankle issues, they'll lose the capacity to express an ankle strategy, and they may over rely on hip strategies to manage our mass as we move. Okay, and so some of the variables here on the left that are important to us when we're loading muscular tissues is looking at loading directions versus trying to isolate or organize our treatment around loading individual muscles, because multi-joint movement is really both, like it says there, like both task specific and direction specific. Okay, we'll also look at the organization of muscles across joints, so looking at both monoarticular muscles and biarticular muscles, because these tissues will bias different roles to handle stress and distribute stress, or to distribute load. With monoarticular muscles biasing more force production behavior, and biarticular muscles biasing more force deceleration behavior to distribute stress, to distribute load over broader surface areas. Okay. And we could even look at it more globally as well, and appreciate that proximal muscles are generally not in direct contact with the external environment, while distal tissues are. Right, so they'll potentially behave a little bit differently to manage that load. But generally, at the bottom there, like it says, we're trying to facilitate variability in a muscle's contractile behavior, with the ultimate goal on a muscular level to really broaden the scope of options that the individual system has to manage stress and to manage load, to handle stress and load. And so we need to think about what kind of strategies the client is using to manage those loads. What kind of strategies are we as therapists using to load the tissues? Are we trying to overcome or produce force when pressure is moving through our body, or are we trying to yield and decelerate forces as pressure and loads are moving through our body? So in the context of our framework here, as you can see at the bottom, we're moving from dissociation to more directional isometric strategies with an overcoming or yielding focus. And then we're moving into obviously more coordinative strategies too. So within the context of where we are with this client case and what we're talking about here, we're falling within the overcoming and yielding portion of this sequence here. Okay. And so once we're confident that the client can express ideal dissociation capacities proximally, and again that's obviously very vague, but we have certain capacities that we want the client to be able to express in certain variables that will give us a good representation of whether or not they can express those capacities as we move through treatment. But once we can express those, we'll generally be able to continue to shift that load distally. And remember, because of the client's symptomatic behavior as well, having more discomfort during and after activity, we may be able to do this a little bit sooner with this individual client, because maybe what we're seeing proximally is secondary to the lack of distal load sharing capacity. Right? Whereas with some clients, perhaps with a little bit more sensitivity proximally, we may be spending the first few sessions working through restoring better dissociation capacities using more progressively challenging strategies. Right? So using the local ankle assessment here, the knee to wall assessment. Let's say we have more of a limitation on the left side, and we can feed this limitation, this unique limiting factor, into our isometric loading to be specific to the client's system and what we're working with. Of course, there might be other kind of local strategies that we might need to deliver to the system to restore some load sharing distally around the foot and the ankle. But what we often find is that a limitation in movement distally around the foot and the ankle is again secondary to a lack of load sharing throughout the entire coordinative structure. And so what we're often seeing distally again is more of a freezing strategy, right? Which is expressed typically in the form of a reduction in the degrees of freedom through increased muscle guarding, increased tone around a joint complex. Right. So what we can do here is we can prove to the nervous system that those tissues can handle stress well, to reduce the need for that freezing strategy. Right, to reduce the need for that co-contraction around the joint complex which we don't want. And so if you look at the image here, again, this is taken from the work of Franz Bosch. So we need to give credit to Franz Bosch and from his book Strength Training and Coordination. And Franz Bosch's work has had a massive influence on the work that we do with IKN. And you can see here, again, this is an image taken from that book here. But you can see the athlete holding an isometric contraction of the posterior limb tissues with the forefoot in contact with the medicine ball through the metatarsal heads here. And this is of course going to drive forces through the posterior tissues of the lower limb, but using some of the using some of the capacities that we spoke about in the last video, where we can observe here that there's a little bit less focus on the capacity to dissociate around the pelvis and the rib cage here. We might need to do this initially with the client that we're speaking about in this case example. We might want to allow for those anti-gravity tissues of the posterior lower midline to unload their anti-gravity function initially when we're putting load through the distal tissues. Right? And we can obviously see here that there's a little bit more of a plantar flexion bias at the ankle. And again, this is completely fine as long as it meets the needs of the individual that you're actually working with, right? And with this athlete, again, it may be a case where they need those kind of strategies, but we can modify this isometric strategy to help facilitate better load sharing in the client that we're speaking about in this case. Where if we look at the image here to the left, we can bias a little bit more dorsiflexion at the ankle, by keeping the heel just gently hovered, very, very slightly hovered from the table, while the metatarsal heads remain in contact with the medicine ball. And this is actually an incredibly hard strategy for many clients to be able to express, because it's forcing them to keep that heel gently, gently hovered, where it's almost, I almost say to clients, where it's gently kissing the table or the ground, wherever you're doing it on. Because what we'll have them do here is we'll initiate that force into the medicine ball, straight down to the medicine ball through the metatarsal heads, and continue to increase that force until we gain leverage to scoop the pelvis up from the table, almost like we're bridging up, and maintain that position while the ankle stays in that position. And we'll very often use this in clients that have a limitation in dorsiflexion, but it also helps to integrate the entire coordinated structure at the same time as well. And we'll typically see in clients that can't express these capacities distally, is they'll begin to lift the heel towards plantar flexion, like you might see here. And again, this is a strategy that we may use with certain clients if we feel as though it's a limiting factor for them, right? And the reason we might see this when we want this is because the client might struggle to allow that ankle to maintain dorsiflexion while load is being distributed from distal to proximal. So it's about the load that you're transmitting through the system at the same time, not just about getting into your position, but you have to load the system at the same time. But what kind of strategies are we using here? We're obviously using more of an overcoming strategy here first, because we're slowly increasing that tension and fighting into the medicine ball to ultimately bridge up off the table here. And then with these isometric strategies, there's lots of variables at play that we obviously can't work through all of them in this short video, but some potential ways that we can progress or add a little bit more challenge to these strategies is by potentially increasing the lever through extending the knee a little bit more. We can drive some internal, external perturbations of the knee in the transverse plane by moving through the knee to try and drive more motion of the hip to challenge the isometric capacity of the foot and the ankle. And we can also shift from using more kind of isometric contractions around the distal tissues to more isotonic contractions at the foot and ankle as well, especially if we have an individual with very poor load capacity at the distal tissues as well, right? So again, there's lots of things to consider here, and the most important thing to consider as well is again being specific with the sequence of loading, right? Moving from dissociation to more challenging strategies distally, and of course respecting the unique limiting factors of the unique case that we're actually working with.